Good morning, everybody. All right, so I'm just gonna get started with the disclaimers as usual. This meeting is being recorded and live streamed on TVW. It will be shared on the State v. Blake HCA webpage. It is open to public disclosure, so please do not disclose any private or confidential information during the meeting. If you want to provide public feedback, there will be 10 minutes at the beginning of the meeting and 10 minutes near the end of the meeting reserved for public comment. Each person will have 3 minutes to provide comment. If you are not a committee member and you would like to provide feedback, make a comment during a particular discussion, simply raise your hand for facilitator awareness, and then we'll know that we need to invite your feedback before moving on to the next item. Feedback that is not provided during the meeting can be submitted via email at any time to hcaesb5476@hca.wa.gov. And with that, I will go ahead and move into the roll call. All right, Michael Langer.
I am here. Good morning.
Good morning. Amber Leaders. Senator Dingra. Senator Braun. Representative Davis. Representative Griffey. Caleb Bantagreen.
Good morning.
Good morning. Don Julian Saucier. Chanel Wolf. Alexi Orr. Amber Daniel. Brandy Flood. Stormy Howell.
Good morning, I'm present.
Good morning, Stormy. Chad Enright.
I'm here.
Good morning, John Hayden. Sarah Melfi Klein. Sherry Candelario.
Good morning.
Good morning. James Tillett. Christine Lynch.
Good morning. I'm here. Thank you.
Good morning. Sarah Gillard. Donnell Tanksley. Malika Lamont.
Present.
Good morning. Addie Adwell. Kevin Ballard. Hunter McKim.
Good morning, I'm present.
Good morning. Representative Taylor. Representative Mossbrucker. Okay. And Michael, before going into public comment, did you want to say any words to kick off the meeting?
Sure. Thank you, Michelle, and thank you for your great job of planning our monthly meeting. Welcome all that were able to make it today. Great to see you. And I know we have a really full agenda today in terms of getting some data shared on the Recovery Navigator program. We talked about that last month as well, and had promised to bring forward our first quarterly update of the data we have. We also have some additional information about housing that you all had asked to have on the agenda. And so we look forward to a very full 2 hours, and we'll be creating next month's agenda based on your feedback as well. So welcome, and thank you all for that we'll be presenting, and all that are here that may have questions as we go along. So let's have a great kickoff to the week, and happy Monday, everybody. I'll turn it over to Blake at this point.
We can't hear you, Blake.
It doesn't look like he's on mute. Can you hear us, Blake?
I don't. Are you going to start over? Is that what you're going to sign off, sign back on? Okay. All right. Looks like Amber, you've got your hand up. Go ahead.
I was just telling you I was here. I thought I took it down.
Oh, okay. Great. Thank you for letting us know.
Yeah.
So while Blake
Michelle,
is,
do you want to do the
yeah.
legislative piece first? Should I just?
Oh, sure,
do
we
that real
can.
quick
Yeah.
while we're waiting? Okay.
Yeah, good idea.
So that might save us a little time, because I know there's a lot happening. So let me come back to I lost the agenda here for a minute. So we're doing great. I'm going to wing this a little bit. We are over halfway through the legislative session. And as DBHR, we've reviewed over 200 bills or so. I mean, there's a lot of activity in behavioral health space this year, as you know. And what you're most interested in, I'm assuming, has related to Senator Robinson's bill that has the SURSAC information or request in it. That is now in gross second Senate substitute Senate Bill 5536. It passed on March 3rd with 28 yeas and 21 nays. So 28 yes, 21 no, and has some new amendments that were adopted in. It will now make its way over to the House. But here are a few of the changes. I'll go through this. I know we just have a couple minutes. It does provide guidance that Washington State Patrol should aim to complete the necessary analysis of suspected drugs in possession cases within 45 days of receipt of the request for the analysis. If that provides that if Washington State Patrol fails to meet the 45-day timeline, does not constitute grounds to dismiss a criminal case, however. This is, again, this is a new piece. There were questions during the hearing about whether or not that time frame is reasonable or could be met, but more of that will come in the debate during the legislative process. So that was one of the changes. Also requires the state to make resources available to assist defendants in obtaining a substance use disorder evaluation within 7 days of the defendant's agreement to participate in the pretrial diversion program. So that's part of the amendment. Another one is require the state to reimburse local courts for costs associated with travel related to obtaining a substance use disorder evaluation. It removes the direction to the court to avoiding discussing circumstances, history, or diagnosis that could be embarrassing to the defendant. Requires defendants to substantially comply with, rather than meaningfully engage with, recommended treatment in order to successfully complete pretrial diversion. Provides that the prosecutor may make a motion for termination of pretrial diversion if the defendant is charged with simple possession subsequent to accepting into pretrial diversion. Number 7, in terms of amendments, removes the requirement that the post-conviction diagnostic evaluation and treatment recommendation be prepared under the direction of the court. Number 8, requires the post-conviction diagnostic evaluation and treatment recommendation be filed with the court under seal. Number 9, permits agencies providing treatment to report any non-compliance with treatment in accordance with the agency's standard practice. Number 10, removes the requirement that the court notify the Department of Health of any failure by an agency to report non-compliance and the associated fine. Number 11, provides that the courts may not sanction an individual for failing to comply with recommended treatment if the individual has made reasonable effort to comply but cannot, either due to lack of available treatment or if the individual is indigent due to lack of funding for treatment. Number 12, restores requirement for Department of Health to hold a hearing in the community before approving the citing of an opiate treatment program. 13 prohibits a health engagement hub from providing supervised injection services. 14 requires the court to inform individuals charged with or convicted of a possession of drugs of the federal prohibition against individuals who are users of or addicted to any controlled substance possessing firearms or ammunition. Number 15 requires the court to sign an order of ineligibility to possess firearms if the required substance use disorder assessment filed with the court indicates the individual has a substance use disorder. 2 more. Number 16 requires the court to reinstate 45 days of an individual suspended sentence if the individual willfully abandons or demonstrates a consistent failure to comply with treatment on the individual's third or subsequent instance of being sentenced for possession under this act. And the last amendment was adds an effective date of January 1, 2025 for the requirement that the Washington State Patrol complete analysis of suspected drugs within 45 days of receipt of the requested analysis. So as I mentioned, we are about halfway through session, and we anticipate that this particular bill will go through additional amendments and changes as we get further along in the session. The session does end towards the end of April, and so we've got probably a month and a half to go or so. But I will stop there. I think that probably took 5 minutes of my legislative update time to go through those amendments of the bill, but we figured that would be an area that you would have a great deal of interest in. So I will stop and see if we have Blake back on.
All right. Good morning, folks. It is time for public comment, and we have 10 minutes set aside at the beginning of the meeting here today, and we also will have 10 minutes at the end of the meeting for public comment. So if you'd like, if you're part of the community and you'd like to make a comment, please raise your hand and we'll get you called on. Thank you.
Hey, Blake.
Yes.
Can I, before we get to public comment, I do see in the chat a reference to another amendment about the 21 day, the mandatory minimum 21 days in jail. We will add that to this, and I think we can get these amendments out to folks so that we're clear about which ones are currently in as amendments as it's gone through the different stages. So thank you for bringing that up.
All right, Lisa.
Hi, thanks for that, Michael. I chatted. I think it's because you're accurately summarizing the most recent amendments, but that is probably missing for people who are not following the day-to-day. Some of the most important aspects of the bill as it currently stands, and I will just, there's a lot in it, but wanted to bring to everyone's attention from my perspective, the favorable side, there remains flexibility for law enforcement to engage in pre-booking diversion. And I think that's going to end up being the salvation of work with individuals in the community if the basic architecture of the bill survives the House and conference, which it may not, of course. I think it's clear that there will be subsequent changes. But from my point of view, the key point to take away is that if somebody gets convicted, this is a pretty radical approach now to tying the hands of both prosecutors and judges, and preventing them from doing the right thing under the circumstances if somebody's convicted of simple possession of narcotics. To begin with, so this is a move away from the learning of the past couple of decades that mandatory minimums do a ton of harm. Very often judges are faced with, they look out from the bench to a person who they know they should not send this person to jail. It will do tremendous harm to their situation, to their stabilization efforts, to their family. And they have to, because there's a legislative determination that the judge doesn't have a choice. This is a feature of current 5536 for people who don't agree to get an evaluation and due treatment. And that would include people who don't believe that they have substance use issues and or know that they can't comply. Then there is a mandatory minimum sanctioning scheme for a second and a third violation of treatment requirements if somebody does go through a suspended sentence, referral to treatment. And then you also heard in Michael's summary, or in, I'm sorry, I had my camera off, I'm not sure who summarized, but the removal of language that somewhat is made more flexible what a court could deem compliance with a service package, so that it's now a requirement of substantial compliance rather than making significant progress with services. And I name all of this to say just how far this framework has gone from what is known about how people get better and how people recover. Recovery services under the SAMHSA definition, even under Washington State Legislature, work in the past, recognizes that people relapse, people struggle, and this idea of compliance in the realm of treatment and recovery just doesn't match. And when people do very predictably, as almost everybody does, struggle now under this current framework, prosecutors and judges are prevented from imposing or from reacting in a way that actually is supportive and constructive of someone's recovery journey. And that, to me, is the most important top line danger of the current framework. Thank you.
Thank you. Any other comments? Go ahead again and raise your hand. All right, Amber. Oh, yeah, sorry, Amber. You are.
That's okay.
a member.
No, it's public
You had a
comment,
question,
and
though.
I'm a
Yeah.
member, so I just wanted to. I had
Yeah.
a question. But I'm not a member of the public, so.
Yeah, we'll give it a second. We'll get to those questions. Teresa?
I also had the same question, I think, that Amber does, which is around the firearm piece. Now, I was watching the committee when they were talking about that, and I thought that that amendment had been voted down. Can you elaborate further on that?
When I watched it, Teresa, I know there were members that voted no, in part because of that, but I believe it did pass. I believe it's still in there. We can confirm that, but the vote on the overall set of amendments was pretty close. And but as they were going through, I believe the firearm piece was still in there.
Okay. Any other comments? Teresa, do you want to make another comment?
Yes, please. Can you tell us more about what that amendment regarding firearms would do? Because it sounded to me like they were saying basically if you're found to be diagnosed with a substance use disorder in relation to the conviction of a crime, that they could remove your right to bear arms. Is that correct?
I do believe that was part of the challenge around this, Teresa. I think we should put in that chat, if we can, a copy of the current bill, and that might help folks along. And then let's take these questions back and let's verify them. This is one area I don't want to get into too much, I guess, a point of view or interpretation without actually having the language shared. Things move quickly, and this is where we get in a little bit of trouble sometimes. So if we can pull out this language and put it in the chat, or we can talk directly to the language, I think that'd be better. And I don't have it in front of me right now, Teresa, so I can't do that. But
Yeah, I posted a link to the bill in the chat. I'll do it again, just so it's fresh.
okay. All right, perfect. Thank you, Michelle. And then let's take down these questions so we can certainly go back and look at them outside the meeting and get back to everybody with the specific language.
Okay, thank you. Last call for public comment. If you want to comment later, you'll have an opportunity. Okay, Lindsay.
Can you guys hear me?
Well, yes.
Okay. My question is, not fully formed yet, and I'm still trying to understand and wrap my mind around a lot of this. If and yes, it's going to probably continue to get chopped up and changed and amended and change how it looks. But I am just curious. The Recovery Navigator program is completely voluntary and non-coercive by nature. So if law enforcement or prosecutors are encouraged to divert and refer people to other services, but then there's this kind of compliance component involved in this, R&P is not providing treatment. It's like a peer support, help you connect to resources and walk with you type of program. So there's no compliance reporting involved in R&P, but if R&P is a viable referral option, how then does that work? If the bill is wanting people to get treatment or get an assessment in 7 days, and what if the referral is to R&P?
Sorry, I got some noise in the background here. I think that's part of what we're going to be sorting out as these different versions go through. If the referral to the R&P is still available, then there's nothing that changes the R&P that, from what I can see. Now, you're all reading it too, if you see something different. I think this is talking about the referral for treatment and the requirements for treatment and engagement with the criminal justice system in that case. And those are the things that they're asking to be tracked. But the referral to the R&P, I don't know that it would change the R&P. If somebody else is reading that differently, feel free to speak up.
I think I can help answer this one.
Okay.
Yeah, so referral to R&P is something that happens primarily prior to a charge, like instead of a charge, right? And so referral to treatment as part of the pre-trial diversion program, that happens once someone's already facing a charge. So R&P happens kind of before the charge situation, and then referral to treatment is the pre-trial, like after a potential charge.
Okay.
Does that answer your question, Lindsay?
Yeah, that is helpful. I'm just trying to make sense of how we are still going to be utilizing all the different avenues to help someone in recovery or toward recovery or health and wellness, instead of, it just feels like maybe keeping the same old thing that hasn't always been super helpful and or not as widely helpful as like having a diverse toolbox might. Okay, I'm going to read in the chat now. Thank you for that clarification.
All right, thank you. And I think we are at time for public comments. Next up, we have Brianna Peterson with our Recovery Navigator Program quarterly reports. Hi, Brianna. Thank you.
Hello, everyone. I'm going to share my screen now. Now I will say I won't be able to see the screen, so if there is comments, Rise Suzanne, would you be able to stop me and read them, please?
Yes.
Thank you.
While we're working on this, Kimmy, did you have something that you wanted to ask?
I just had kind of a comment because I know the RMPs are different. And the RMP here in South King County, we have gotten many people into detox and treatment within 24 hours of the law enforcement referrals for diversion. So I just wanted to say that, I mean, we are doing that. Thank you.
Thank you. All right, Brianna, back to you.
Okay. So what I'm gonna do, instead of talking about each slide, because it's gonna take some time, is I'm just gonna talk to you guys about the reports in general, and I will slowly go through the slides. You will notice that there has been some changes from the information that was shared in February. Since February, we've been having many discussions internally and with our data governance group about sharing certain numbers, particularly smaller numbers, those under 11. We've tried to discuss it with the data governance group about sharing as much information as possible, but due to HIPAA rules, we are not allowed to share any numbers under 11, so you will see them indicated here in all the slides. We are working on, based on the comments that were had in February, we are working on updating the race distribution. Unknown will no longer be an option. It will be either other race or not collected. And so that'll hopefully help us get some better data in the race distribution. Again, you'll see these under 11 a lot. We're working with the data governance group to provide better visuals to be able to represent the data in its entirety without violating any HIPAA laws. Again, you will see areas where information is redacted because we didn't want someone to be able to reverse engineer some of these numbers to get to those smaller numbers and end up violating anybody's personal identity. These workbooks are, I guess, in the works. We are, the data governance group is actually, I see the comment. The data governance group is actually based on internal HCA individuals. Yeah, they're an internal HCA body who determines a lot of the data that we share, especially the public data that is shared. It would be, I'm sorry, can someone read that comment?
Caleb is asking, it would help when suppressing data to give the percentage missing or the inverse of the percent of data shown. Is it 1% of 10%? Some sense of scale would be helpful.
We're working on creating the percentages just so we have better, so we can show the data in a better way. We are working on improving this. Again, we've been working a lot since February's meeting, almost nonstop. Myself, Suzanne, and Ryan, trying to get these to be presentable with the data governance group. We worked with them multiple times, met with them multiple times. This is the best that we can come up with the time crunch, but we are working for the next quarter to have a lot better representation of the data. So I apologize for that. We are working with the BHASOs to create cleaner data and better data to present as well. We had a lunch and learn in February. We're going to have another work group tomorrow, I believe, to create better options to really narrow down the specifics of what we are providing to people, other than selecting other or unknown. We really want to drill down exactly what we're doing and providing. So not only we can represent what the BHASOs are doing, but we can also represent what we're doing within the communities. This meeting is also in part of taking in any feedback that you guys might have of other ways that you want to see this data, the other ways that you would like this data to be broken down. Again, this is a work in progress. This is the first time we're sharing this. So we're excited to receive any data that you guys, any feedback that you guys have on representing the data. I know here, hope to get to case management because I wanted to talk a little bit about the contingency management. So Caleb had a comment in February. Yes, sorry.
Yeah, I'm sorry. This is Michael. I may have missed it, but unless my slides are behind, the first slide was the state numbers. Would it help to take a moment and walk through that first slide so that, because we may have some folks that weren't on last month and so forth, would it be helpful to go through that first slide of the statewide data? And then I think what you've been showing afterwards are the different regions coming through and where you can see the suppressed data. But were you planning on doing that in a little while? I don't want to get ahead of you there, but if not, if we can go back and just share that first slide, I think it'd be helpful for the committee.
So I believe that most of you have seen the workbooks that the Recovery Navigator programs are using. And so we pulled out some of these numbers. We thought that this would be one of the better representations of the data, and given all the feedback that you guys have given up until this point of what you guys wanted to see, how many referrals, how many law enforcement referrals, how many people are actually being enrolled in case management, what type of case management, and then the gender and race distribution. And so that's this page. The average response time, I know it looks a little funny. We are working on creating better numbers for that. Instead of individual numbers, we're hoping to have a drop down, and then we can better represent each region, either urban or rural, if they are meeting the requirements of those referral response times.
I think we lost the share of the slides.
Oh no.
Yeah.
Sorry.
Great. There it is again. Thank you.
There it is. Okay. Nope. Did I lose it?
We can see it now.
Okay. So in this slide, you can see the different enrollments in intensive case management and light case management. If they decline services, and these that are currently in outreach status, just meaning that they're still developing that rapport with those individuals and they're continuing to make those connections. I will get to the case management. So as you can see here are the suppressed numbers. Again, we're looking at better ways and actually cleaner data, just so we can represent those numbers a little bit better. We are looking at updating the visuals just so that we can read all the information, because there's just a lot of information to try and pack into these. So we are looking for better ways to have a percentage, not just the number. I see comments. Ryan, Suzanne, can you read the comments and see?
Yeah,
Can everybody
Caleb.
see the slides?
Yes, we can see them. Caleb said it would help to also have percent, not just numbers, since we are trying to identify and address disparities.
Okay.
And Melody said, any thoughts about aligning the data elements in R&P with peer Pathfinder outreach programs?
I believe that's going to probably be a discussion when we start looking at edX and we have better validation tools available. So that'll be a future discussion.
Okay, and then Amber was clarifying, she was talking about the numbers under 11.
No, I was
not talking about the numbers under 11.
So in the regional slides for Pierce County and King County, could you maybe go back to that real quick?
And I can address that. I threw it in the chat, but part of why those were redacted is, if we had 105 follow-ups in King County, if we listed the number of outreaches and they are less than 11, it could tell you how many those were. So rather than just listing them as under 11, we listed them as redacted, so we didn't have an exact count. It was the guidance of our data utilization committee to do so for those categories.
I just thought it was weird that the two, King County and Pierce County, that had like probably some pretty high numbers, were redacting outreaches, and that it didn't seem like it added up to me.
I will say the data utilization committee process was very, there were a lot of comments and feedback that we had to incorporate just in the end of last week so that we could get it out and be shared. And yeah, we will take that feedback to heart as we work to improve this process.
Yeah, we fought really hard to try and share as much information as possible, but we also have to take into consideration not violating anybody's personal identity. So that was something that we had to consider, and we're overruled on sharing some of the smaller numbers. We know that it's very important to share the law enforcement referrals because of what type of program this is, and so we try to fight for that, but we're overruled, and that's okay. We will continue to work on updating these reports in a better way. Again, we are working with the data governance groups. They gave us feedback, and with your feedback, we'll be able to update a lot of these to give better representation of the numbers. The percentages numbers were something that was talked about internally as well, so thank you, Caleb, that just reinforces it. So we will be looking at and updating this slide deck.
We've got a hand up as well. Yeah. Malika, go ahead.
It also, so just to drill down on, I can't see the chat, by the way, so I don't know what people are talking about. So if somebody's already said this, then I apologize for saying it again verbally. It is just really concerning to me that we are not, it doesn't feel like the guidance from the data work group is manifesting in what we're seeing right now. And we have so many times throughout the process of, this 5536 and so many other bills, there have been direct questions about whether or not people are engaging in service. And the fact that we don't have data to be able to demonstrate that people are engaging and what that has meant across communities in our state is helping to contribute to what is going to probably be a much more harmful ecosystem as far as the mandatory minimums. There wasn't information to be able to push back. So I just want to uplift that there are real world consequences for not having the good data.
Thank you.
No, thank you, Malika. Like I said, we're trying to present this data as best as possible, and with the feedback internally and externally, I think we'll be able to get to a better point in presenting this. I will point out each slide deck does have a success story in them in the case management slides. So if you get a chance to review them, take a look. Some really great stories in there. We did notice that when we were developing this report is that we didn't have any race and gender data in the case management, and so that was included in our version 6 that will be utilized in Q2. We're hoping that in Q1 we'll have better data, so you will see that the next time. And then when that Q2 data comes out, we're really hoping to have some really nice clean data and get a really good representation of what the RNP is doing out there. I know. And that's the end of my slides. Does anybody have any additional questions?
See, Caleb's got his hand up.
Hi. I'm wondering, are there also ways with downstream data like healthcare data, SOAR data, or treatment data to document referral sources? We've done a little bit of that with some of our small studies about referral sources, but you're trying to document this sort of real-time process flow. And I'm just wondering if there's going to be complementary data getting built into the other systems. Either you can track at the individual level, obviously that's ideal. That's what we should be doing. If we can't, to at least have different data systems giving us a sense of what are the number and type and changes in referral patterns for folks coming in. The treatment data system is the obvious one. So, and I know that's been, I'm kind of looking at Michael, I don't know who else knows these, but in terms of this has been disaggregated around the state, but what's the capacity to do that? Again, in the beautiful target data, I just said that to make Michael smile. You could look at referral source quite readily and actually add referral sources. I don't think there's any sort of central capacity to do that, but that seems like that would be a nice complement to this data.
So Caleb, I'm going to interject here for a moment. Make sure I understand what your suggestion is as we have collect referral sources for other systems like our behavioral health data system that collects the treatment data, is RMP a referral source that's built in, or could it be built in so that we can collect it, get you information that way as well? Am I hitting it, what you're asking about?
Yes.
Okay. We could certainly look into that. Yeah. I think BHDS is probably the primary one, but there may be others as well. And I think as this data accumulates, right, if we go quarter by quarter, we may still have these suppression issues, but as it accumulates sort of year to date, we should be able to avoid some of the suppression and small number issues so that we can actually tell the story better.
Well, it's a very different side of the data. I mean, we really want individual level linked data over time, but we also know that the ability to identify the same people through these data systems can be difficult, if not impossible, due to data sharing agreements. So at the same, or data access rights. So at the same time, trying to figure out, are we doing a complementary work on the other side to see, are we seeing a change in treatment intakes from different data sources, from different referral sources?
Yeah, good point.
See, Susan had made a comment there. It's important to point out that the total number of referrals is 7,170. The state, which does speak, to number of individuals who have been helped through RNP in the first year. And then Sharice's got a comment there as well. I was wondering about the word treatment being defined. Does treatment here mean a formal SUD program, or is it medication and counseling outside the SUD agency? Also, an accepted form of treatment. Do you have any comments on that question? Or?
I mean, I'll just say it's a major problem with data over the last 20 years, right? We went from a specialty addiction treatment system to a lot, if not virtually the majority of opioid disorder treatment being provided in healthcare settings, which don't have the same data requirements. You know, you have to go to Medicaid data and they're not going to track that referral source. So it's super important, and it goes back to the point even further that Lisa was raising, that it's a critical issue about what is treatment. And the language in the laws, 5536, potentially getting more flexible. That is it treatment or is it services? Is it completion or is it engagement? Like these have major consequences and implications for individuals first and foremost, but obviously for how we evaluate these processes.
Thank you, Kel. Okay, any more questions for Brianna? Before we move on?
Yeah, for Teresa, let's, again, we'll look at the law and see if the definition's in there. My understanding based on how the conversations is going is they're probably looking at treatment as your more traditional outpatient residential when referrals are made through the court system and so forth. We certainly made the case for medications, for more of the engagement, harm reduction, things of that nature. I'm not sure that the language is in that definition, but we'll look for it and let you know, Teresa. Sorry, Caleb, or Blake, I just want to make sure that we gave her a complete answer, and then we'll get back to that.
Yeah. Okay, we are back to discussion on state housing programs, part 2 of 2. So Matt, Melody, Lisa, and Heather, are you ready to go?
Yep.
All righty, we'll let you take the screen, and thank you.
All right, Matt, you're up. Are you on? Matt Christie?
I am on. Can you hear me?
Oh, there you are. Okay.
Hey, sorry, my mute button was stuck.
No worries.
Clean out my keyboard. Let's see. I'm gonna pull up a slide deck here, and then I'll introduce myself for the group. All right, believe that is up. Good morning, everybody. My name is Matt Christie. I am so happy to be here. I work at the Healthcare Authority in the Division of Behavioral Health and Recovery, on the Recovery Support Services team, and I supervise the Foundational Community Supports Program, and was asked to present today on just a high-level overview of what it is. I'll just jump in. So what is FCS? Foundational Community Supports is a support service program under the 1115 Medicaid Transformation Project that we have in the state of Washington. We provide supportive housing and supported employment services as Medicaid reimbursable services as an innovative program that was launched in January of 2018. Just a high-level overview. Since then, we've enrolled and served over 31,000 individuals. We've built a provider network of over 180 providers with over 500 locations. And we exist in a space that's of innovation, I would say, with the Centers for Medicare and Medicaid. MTP, or the Medicaid Transformation Waiver, is a 5-year renewable waiver that allows us to use Medicaid funds in innovative ways and demonstrate the effectiveness of new programs and services. And FCS is really designed to address social determinants of health by removing barriers to stable housing and employment, promoting self-sufficiency, and of course, recovery. Who is eligible for FCS? Because we are under a waiver program, FCS is not an entitlement benefit for everyone who is on Medicaid. So we have target populations for our support services. So the first sort of criteria is that we do have to have that federal Medicaid enrollment, or Apple Health. So for those of you who are aware, Apple Health is the name of our Medicaid program in the state. For our supportive housing services, you have to be at least 18 years or older, and for supported employment, 16 or older. And you have to meet requirements for complex health needs to show that you have the medical necessity related to either mental health, substance use disorder, needs with activities of daily living, or complex behavioral or complex physical health needs that prevent you from finding and maintaining stable housing. You must also meet, or an individual, sorry, must also meet several risk factors to help further determine someone's eligibility. For supportive housing, these are things like chronic homelessness, frequent or lengthy institutional settings, stays in institutional settings. For supported employment, these are things like you have a referral for housing and essential needs, or age blind and disabled program, HEN ABD, difficulty maintaining or obtaining employment due to age or physical impairment, physical and mental impairment, etc. I won't go through all of these in great detail, but we like to talk about FCS as a really high intensity support service that's it's designed to help people on Medicaid who have very high level of need as support. Again, these are support services that are designed to help people find and maintain housing. And these targeted benefits are founded on evidence-based practices, very specific principles. For the supported employment program, we follow the individual placement and support, permanent support, and for housing, permanent supportive housing, the SAMHSA toolkit of permanent supportive housing. For both of these support services, you can see on these principles that they're very complementary of one another. They both value choice. I think just for the conversation of housing today, because that's really what we're here to talk about, I'll just focus on those principles. So founded on choice of housing, creating access to housing, making sure that there's integration within the community, that the housing is safe, decent, and affordable, that there are rights of tenancy. So that's one thing, we get a lot of questions about the age criteria. One of the reasons that we have 18 years or older is so that participants can have that rights of tenancy and have a legally binding lease in their name to make sure that housing is independent. And we want to also value the separation of housing and services and make sure that the services are flexible and voluntary. And I'll just pause on the word voluntary for a moment, coming back to the original sort of structure of foundational community supports. Because this is a Medicaid benefit, it's a voluntary program. So we want to make sure that participants want to be in the program. It's not a requirement to be in the program. And service engagement is voluntary. With the Foundational Community Supports Program, we've really created what we like to call a no wrong door approach for referrals to the program. And what this means is anyone can refer a potential enrollee to the FCS program. This could be an individual referring themselves, a referral from a family member, from their, maybe they're working with a behavioral health provider, or they're engaged in services through the Aging and Long-Term Support Administration, managed by DSHS. Or they're in another program run by BBHR. I think we'll be sharing these slides afterwards, but there are a lot of hyperlinks in here for additional resources. We've created a quick reference guide that kind of goes through these eligibility criteria and explains what the services are to help determine who might be eligible. And all of these referrals, so if you think about this from a Medicaid health insurance model, we have a third-party administrator, AmeriGroup, who manages all of the authorizations and enrollments in the program. So what this looks like, AmeriGroup is the, as I mentioned, contracted third-party administrator of the program. They handle all of the enrollments and send those to us weekly for service authorizations. They also pay claims and encounters and track and report, pay claims and track encounters and report those back to the state. And they're responsible for managing our provider network. And so with FCS, we have a specific provider network for providers to be able to provide these support services. What that kind of looks like, if you think about Medicaid, traditional health service, we, for these support services, rely on community providers who aren't necessarily your traditional Medicaid billing providers. These are things like housing authorities, community nonprofit organizations, behavioral health organizations, faith-based organizations. We have also just kind of a wide range of providers that historically have not been able to bill Medicaid. And one of the advantages of having a third-party administrator is we're also able to bring in these new providers to Medicaid and have them bill and track claims the way that you would outside of the waiver for medical services. One thing that I will highlight, yes, AmeriGroup is one of our 5 Medicaid managed care organizations in the state, but this does not mean that an individual participant has to have AmeriGroup as their insurer for their Medicaid. So any of the 5 plans can be, their main Medicaid. It just means that for enrollment in foundational community supports, all of that is managed by AmeriGroup. Just a quick overview of our provider network that I mentioned. We have 184 contracted contracted providers in our network, divided by supportive housing, some who provide only supportive employment, and the majority provide both services, and just over 500 locations statewide. And we have a map on our website. This is just a screenshot, but when you go to the link on our website for the map, you can hover over each of these locations, get the contact information for each provider, and it's dynamic. We update it monthly, and a very useful tool to see where an FCS program might be in your region or in your county. And then I've also provided some additional information on how to become a provider. Again, this is all managed through AmeriGroup. We have a provider manual that goes over information on credentialing, as well as a really detailed overview of the services. I must have dropped a slide off on here that had an overview of what the services look like, but they complement each other very nicely between employment and housing. If you can think about it as like, what are the types of supports that someone needs to find and maintain a stable job, as well as find and maintain stable housing? They're kind of divided on pre-tenancy type services. So maybe applying for housing, getting an ID, figuring out where someone wants to live, the type of housing they need, and the type of supports they need. In addition to the support services that help maintain that housing once they do move into housing. These are things like potentially paying rent, managing relationships with neighbors and landlords, etc. So quite a few different types of supports. Again, this provider manual really goes into all those details on what that looks like. For anyone on the call who might be a provider who's interested in the Foundational Community Supports Program, I've also provided that link for the AmeriGroup website that has even more great information. We do have measurable outcomes for the program. One of the benefits of using evidence-based practices is that you can collect data and measure outcomes. And some of these, this is a couple years old at this point from 2021, but for our employment program, we did see an overall increase in employment rates for our target populations, increased in hours worked and wages earned, as well as decreases in arrest rates. One of the things that we've been tracking with the waiver and hope to have seen and are really digging into maybe more information as to why we haven't seen it, but we haven't measured any or haven't seen any significant decreases in emergency room or inpatient service utilization for employment. And then on the housing side, we have seen significant positive impacts on transitions out of homelessness, by which people did not return to homelessness after participating in the FCS program. More people are being placed in housing projects funded by the Department of Commerce. My colleague Melody Faisal from the Department of Commerce will be speaking briefly, be speaking in a moment here, kind of about a new housing program that we're developing. We've seen higher rates of in-home care services among our supportive housing enrollees. But similarly to our employment program, we haven't seen significant decreases in emergency department or inpatient utilization. With that, I know that was a quick overview, but I do want to hand it over to my colleague Melody, who will talk about the Foundational Community Supports Program, as well as the new Apple Health and Homes initiative that we are jointly putting together. Take it away, Melody.
Thanks, Matt. Go ahead, next slide. So I'm Melody Faisal. I'm the Managing Director of the Office of Apple Health and Homes and Permanent Supportive Housing. And in 2022, a piece of legislation was passed called the Apple Health and Homes Initiative. And this piece of legislation essentially established the Office of Alpha Health and Homes within the Department of Commerce. And it really builds upon the Foundational Community Supports Program to really kind of bring what we call the three legs of the stool together, to really help individuals. And what's really interesting and unique about this initiative is that it's really trying to promote and say that housing is really a social determinant of health, and that as individuals experiencing behavioral health and mental health and substance use and chronic health conditions and long-term care needs, it's without having housing and wrapped around those individuals, that they're not going to be as successful with treatment if we don't bring and really address their housing component of their life. And so we really are really elevating how housing is a part of that holistic process of treating and bringing all of those pieces together. So how do we bring housing into the conversation, into the support system? And so it's bringing housing as part of the service delivery with the foundational community supports. If FCS is a Medicaid benefit as part of that person's healthcare service delivery continuum, how can we bring the housing as well as rent assistance to wrap a comprehensive package around that individual? Originally, this was actually coined as a prescription for housing, and that's just a concept in mind. We really don't have prescriptions for housing, but the idea of that concept of being able to recognize that we're really only treating a portion of that person if we're only releasing that person back to homelessness. And so how do we actually wrap this holistic part of the service delivery system of bringing housing to that person, supporting that person with these other components, the social determinants of health. And so what this program does is we're really trying to actually bring bricks and mortar, build housing, bring support services, bring housing rent assistance to those individuals that have those complex needs. And so we call it the three legs of the stool: permanent supportive housing. Next slide. So we'll be building upon this, and really sort of a subset of individuals in the Foundational Community Supports Program. So as Matt was talking about FCS, you'll notice that actually if you line up the Apple Health and Homes eligibility to the FCS eligibility, it is a little bit of a condensed version. There is one line that we're also working through around individuals that are not currently on Medicaid, and we're still working through some processes for people that may be currently homeless or assessed as likely eligible to be on Medicaid, but aren't currently on Medicaid. We're working through some of those issues, but you'll see this is a little bit of a smaller cohort of individuals on the FCS program that we'll be working through. So there right now are about 9,000 individuals enrolled in supportive housing in the FCS program, and we automatically can't just provide housing for 9,000 individuals. It's going to take some time for us to build the inventory of housing to be able to wrap those resources around those individuals. And so this is going to be an incremental approach as we build the capacity to bring those housing and rent assistance resources to individuals enrolled in the program. But that is basically our goal. And it's really a paradigm shift for the housing world. So as many of you may know me, I'm actually I'm kind of from the behavioral health system, and I'm now have sort of infiltrated the housing world. So next slide. And so I'm really trying to also help think about the housing world differently, and it's sort of a shift for the housing world to be, I think from any housing is good housing to how do we make a better match for people in housing. And so this concept of permanent supportive housing. Permanent supportive housing is a very specific definition in the housing world at Department of Commerce. And we are really investing and expanding permanent supportive housing. I think last month I presented a little bit about some really strong investments that are happening just recently. And if you're watching the governor's budget and legislation, there's a lot of attention being paid about, we have a housing crisis in Washington state. We have not built enough housing to keep up with the population demands. We need more housing. And with that housing demand, we have a housing crisis. We're also paying attention to how much housing we need for people that are very low income, and specifically people that need permanent supportive housing. And so there's a very specific definition of permanent supportive housing, and Apple Health and Homes is a subset of that permanent supportive housing. So we'll be paying attention to both of those. We're estimating in the next 20 years that we need approximately 120,000 units of permanent supportive housing for both Apple Health and Homes, as well as the broader permanent supportive housing needs. Next slide. I want to also draw your attention that permanent supportive housing can come in a lot of different models. So you can have tenant-based rent assistance in scattered site units where you're working with private market landlords. You may have a single site tenant-based rent assistance model where maybe you're working with a hotel or motel or an apartment building. You may have master leasing, and the Healthcare Authority is actually working on a master leasing toolkit. So we're very interested in all sorts of different models. There's not just any one way to do permanent supportive housing. I think a lot of folks sort of tend to see permanent supportive housing as large apartment buildings, and that's what we call project-based single site permanent supportive housing. That is certainly a very common type of permanent supportive housing, but I think this is where we need a paradigm shift, not only from the housing perspective, but really making a better match in what kind of environment does that person need to be successful. And I think that that's really where the Apple Health and Homes initiative, where we're partnering with foundational community supports and how to make those matches. What kind of environment does that person need to be successful? And the next slide really kind of shows some of that, some of those situations. Go ahead, next slide, Matt. Where, if a person who has a substance use disorder, who doesn't want to return back to the community where they began, go back one, where they began using, how do we help that person really think about the environment that they need to be successful? But if there's only options for project-based housing in a specific location, how do we actually develop more capacity for other options and tailor the environment that that person needs to be successful? If a person has convictions, but the project-based housing has multiple populations in that because of their funding streams, how do we make sure that we're meeting all individuals that have housing needs? And so we have a lot of work to do in the housing world to make sure we're tailoring the housing and matching people with the housing that they need to be successful. And so it's really about developing stronger relationships between the assessment and that's happening in foundational community supports and developing inventories of housing and making that match. And that's the paradigm shift that I hope that the Apple Health and Homes initiative is really going to demonstrate as we launch this initiative in the next year. Next slide. So how is this going to work? So people get involved in foundational community supports. Once they're involved in foundational community supports, that assessment of what kind of environment do they need to be successful? What's their support needs? What does housing look like to them? How what kind of support do they need to be successful in housing? What does that ongoing support need to look like? And they're going to be working with a coordinating entity. That coordinating entity is also going to be a mayor group to authorize access to the housing inventory that we at Commerce are developing for the Apple Health and Homes Initiative, whether it's the inventory of housing or rent assistance through project-based vouchers or tenant-based rent assistance. And we're going to create sort of a pharmacy or inventory, and we're going to try and match people with their needs. And that's essentially the concept of what we're trying to establish in the Apple Health and Homes program. And so we have a lot of work to do. We're meeting constantly with our partners at the Healthcare Authority, as well as AmeriGroup and Department of Social and Health Services, our other partners in this program. And so that's, we're also building the inventory. Next slide. We're also developing capacity we've launched our rent assistance third-party administrator. We're developing capacity grants to help further partnerships between healthcare and behavioral health and housing providers. We're helping some of our housing providers explore adding FCS to their book of business. We're also providing technical assistance through enterprise community partners to develop more housing capital. We're also providing technical assistance to those housing providers on permanent supportive housing, and we've just recently launched our capital program to build more permanent supportive housing in alignment, build that inventory for capital for the AHA program. Next slide. And these are some more resources. We've got, these are a lot of the resources that Healthcare Authority has been doing, just a tremendous amount of resources on the pathways to housing. Kudos to Kimberly Castle for and all of the work on the HCA team. If you've not seen Pathways to Housing, what a tremendous resource that this website has on resources, training, information, just a lot of resources on FCS, as well as on the Pathways to Housing website. So I think I will pause and see if we have any questions. I think there might be one more slide, Matt.
This is Dr. Barrera with the AmeriGroup. I was wondering, in your data, you showed the number of people in FCS and you guys talked about it. About how many people are not included in that? Do we assume are homeless and needing help, but are not among those 9,000?
It's a great question. This is Matt Christie. So currently we have, I think in the whole program between both services, around 11,000 people enrolled. At any given time, we estimate around 50% of those are currently homeless. And more broadly, and I can follow up with some information if that's helpful. I think just the general Medicaid population is roughly 11% of that is homeless at any given time. And just off the top of my head, it's like 1.2 million people enrolled in Medicaid. So probably looking at with a broad definition of homelessness, 120,000 people on Medicaid at any given time. That includes things like unstably housed and couch surfing. So quite a large,
Thank you. Yeah.
Large number. Not all of them would be eligible for foundational community supports, but just off the top of my head, that was the last more broad Medicaid measure. But within FCS, around 50% of our eligible population is homeless within a given month.
Okay.
Research and data analysis is going to be coming out with a report here pretty soon on, it was actually a proviso that they are required to do to estimate the number of individuals that they believe need permanent supportive housing. And so they're by 2025. And so I can't say the estimates, but there is going to be a report that's going to be generated by RD Research and Data Analysis here pretty soon. That's going to be giving some of those estimates.
So
It's
given those
significant.
that forecasting being so large, are the programs that are being held up now are getting started enough to support that many people, or do you think just what would be the percentage of?
We again, we just can't build enough housing, fast enough. We're just so far behind on, so if you're not familiar with House Bill 1220 that was passed, I think in 2020 or 2021, it is on the Department of Commerce website, and I can put a link. That bill required the Growth Management Act to project how much housing is needed by 2044 across all counties with the population growth, either low, medium, or high population growth. And so they've split out the housing needs by different area median income levels. And so that is what I was referring to when I was saying that 122,000 units of permanent supportive housing is needed in the next 20 years. And that's just the PSH housing needs. That's not all of the housing needs. And so I'll put a link that Commerce just actually released those findings, that methodology. And so I'll be happy to put a link in the chat to that information.
That would be appreciated. I do have one more follow-up, comment and question is, Matt, during your referral source slide, you didn't have the managed care in there as a referral source, but I know we refer our own members when we see them in treatment, they've met the criteria, we'll refer to the FCS program because it's still considered like an external referral for us, even though we run it, it's externally run. Just thought that it would be nice, since I work in AmeriGroup, that if the managed care had more, maybe it wouldn't be nice, but more credit. We need to be partnering with the providers better to make sure that these members are getting referred, because we see it, maybe it's too late, we're doing a referral and then the member's discharged already, and then it's hard to find them. So, but it's still, we are a source of referral, and if we could still continue to promote that within all the 5 MCOs to be referring members to FCS as we see, members that meet that criteria.
Thank you. Yes, and a good note to add that to the slide. But yeah, we do get referrals from managed care organizations, and we are in quite a few different meetings. Even just this last Friday, around House Bill 1860, talked about referrals to permanent supportive housing programs, including FCS, from managed care organizations. And it is something, when we're looking across the board at discharging from institutions, or, when a managed care organization knows of a recipient who has housing instability, kind of at what point and where the different touch points with the FCS program, and always working on, making that pathway to FCS as clear as possible and as easy as possible to get connected to. But yeah, great comment and thing to highlight.
I want to make sure we have time for some Q&A for the other 2 presentations. So if you have any additional questions, please hold those till the end of these next 2 presentations. And thank you so much, Matt and Melody, for your presentation so far. Lisa, are you ready?
Yes. Good morning, everybody. My name is Lisa Bennett Perry. I am the Recovery and Community Supervisor for the Healthcare Authority in the Division of Behavioral Health and Recovery. Michelle, just doing a time check. We have 10 minutes, right?
Yeah, that's right. Yeah.
Okay. So I'd like to share my screen. I'll do it as fast as I can. I'd like to cover our 2022 Proviso 96 Housing First Expansion Project. HCA DBHR is tasked in Proviso 96 to create and expand access to no barrier and low barrier programming using the Housing First and Harm Reduction model. These models are designed to assist and stabilize housing supports for adults with behavioral health conditions and those with co-occurring disorders. You're saying you cannot see my slide. Let's try this again. Sure. I'm not new. Share. Here. From beginning. Okay, let's try this again. Sorry. Is it showing now? Okay, wonderful. The provider states that housing supports and services shall be made available with no requirements for treatment for the behavioral health condition, and supports must be individualized to person's needs and wants. By Housing First, the key principles of Housing First is immediate access, choice and self-determination, recovery orientation, not simply focused on meeting basic needs, but on supporting recovery. It's individualized, it's person-driven, supports, recognize that individuals are unique, and so are their needs. Also, there's social community integration as being a big part of your recovery, and socially supportive engagement and opportunity to participate in meaningful activities. Harm reduction aims at reducing the risk and harmful effects of substance use. And it emphasizes the choice that people must think for themselves and follow the path they want. Harm reduction works by addressing broader health and social issues through improving policies, programs, and practices. The Housing First expansion priorities were to expand the Housing First projects across the regions. The initial or an intent of the proviso was that the Healthcare Authority would provide the services, and Department of Commerce would then provide the capital funds needed to be able to do this, and housing subsidies. But the actual capital funds did not come with this proviso. So what we did is we built off, in partnership with Department of Commerce, we built off some of their existing capital fund contractors. That includes Catholic Charities, Housing First Grant in Pasco, Washington. They're scheduled for an open house on April 27th. Capital Charities received capital funds for a startup of 59 units, affordable housing for individuals experiencing chronic homelessness, and over half of those individuals identified as Hispanic or Latino. Agencies that, and we also prioritize based on agencies that already had internal housing units available and that were committed to providing individuals and families that are also experiencing behavioral health challenges and barriers to housing. I'd like to point out that individuals to receiving these services do not have a criteria of Medicaid. There also was agencies that were on up and coming funding that was available to, and not just agencies that had housing available. So it was a little bit of both. HCA also prioritized agencies that demonstrated diversity and inclusion for marginalized and underserved populations. Here are the 10 organizations. We were able to, with the funding that we received, we were able to contract and provide funding to 10 agencies in 8 regions across the state. The Housing First model allowed us to, the Housing First model staffing model was for 2 peer counselors. That's for internal housing and external housing. In other words, it could be project site, or it could be people that are living in their own housing or individual houses. Also, there will be 2 housing specialists. So again, that could be project site support, or it could be scattered site support. and then 1 supervisor and 1 residential manager, housing first services and property manager. The goal is your residential managing should be separate from your housing supports. So that also was funded, so they don't put them all together, which is what occasionally happens. The Housing First program, the resources that we have available, we were able to hire a Housing First program manager. Her name is Kathy Geisler. She's responsible for contractor performance and technical assistance. We also have contracted with Advocates for Human Potential for a series of Housing First trainings and a program manual and ongoing support, and research and data analysis for managing, compiling the data, and then Department of Commerce for reporting platform into HMAS, or Homeless Management Information System. And if there's any questions, I'd be happy to answer them.
All right, maybe folks will have questions after the next presentation, at which point you can ask any of the presenters. So thank you so much, Lisa, for that. Heather, are you ready? And I'll go ahead and pull up your slides.
I am, thank you.
Okay.
So my name is Heather Maxwell Reichart. I am the Recovery Residences Oxford House Program Manager at HCA within the Department of Behavioral Health and Recovery. And super glad to be here. It's my first presentation. I told Mo I promise I won't cry, so I'm not gonna. So yeah, I just appreciate the opportunity to come and talk a little bit more about Oxford House. So Oxford House is peer-run, self-sustaining, substance-free housing. Next slide, please. So these numbers were gathered at the end of 2022. There's a total of 347 houses, 246 men's houses, 101 women's, 42 women with children, 23 men with children. That brings us to a total number of beds, 3,026. That's 1,992 men's, 981 women's. And there was also a report of 1,385 people identifying as receiving treatment for opioid use disorder or medication-assisted treatment. Next slide. I like facts, and I dug up the cost-benefit approach to share with you all. So fact, during 2022, residents in the Washington network of Oxford houses will pay approximately $8 million for their own household expenses for the 347 houses now in the state. A traditional halfway house system to accommodate the same amount of beds would have cost taxpayers between $61.2 and $104.1 million a year. So instead, the state is paying Oxford House Incorporated a fraction of that to develop and maintain the statewide network of 347 self-supporting Oxford houses in Washington state right now. Next slide, please. So in 2011, the federal government, SAMHSA, listed Oxford House as a best practice on the National Registry of Evidence-Based Practices and Procedures. Oxford House gives people in the recovery from all backgrounds who choose abstinence-based living a great chance at long-term recovery. Also, Oxford House saves millions of tax dollars to the state and local communities. Next slide. Anybody who chooses abstinence-based housing is eligible and can do well in Oxford. That includes co-occurring veterans, drug court, step court, mental health court, reentry from incarceration, and those on medication-assisted treatment. Becoming a member, you can fill out an online application by visiting oxfordhousevacancies.com. Whoops, I lost my notes. Hold on here. So, or you can call a house to set up an interview. It's a democratic process, so you must get an 80% yes vote by the members of the house to be accepted. If new members are accepted in, they can move in immediately. At oxfordvacancies.com, you'll also find the online application information on what days the Oxford House does interviews, phone numbers to call to set up interviews, as well as the address of the home and also maybe a picture of the house, which is nice. Next slide, please. So Oxford House opened its first house in 1975 in Silver Springs, Maryland, and has been successfully operating under the Oxford House model for close to 50 years. Some of the benefits are 24/7 peer support, accountability, responsibility, safety, stability, self-efficiency, abstinence-based living environment, and personal growth. Next slide. So recovery, a process of change through which individuals improve their health and wellness, live a self-directed life, and strive to reach their full potential. I love that. See, I'm not gonna cry. Sorry. Not very professional, but when I have gratitude, I get emotional. I just wanted to say for this particular presentation that we recognize there's many pathways to recovery. Abstinence-based recovery housing is just one of the many. And next slide. This house here is one of the more recent ones, opened up in Richland, Washington. It's a beautiful home. A lot of the Oxford houses are really nice homes with the average of 8 beds. They're in good neighborhoods. They have long-term leases, supposed to have plenty of parking, close to public transportation, close to employment opportunities, and also close to services. And that's pretty much what I have. I didn't include my contact information, so I'll put that in the chat. Yeah, and I don't think we have any funding information to include at this time. So that's it.
Thank you so much, Heather. So we do have about 8 minutes for Q&A for any of the presenters. And I see that Deontay, your hand's up. Go ahead.
Yes, good morning, everybody. Happy Monday. Heather, my question was for you. I do love the work that all of our community members are doing, especially some of the reentry spaces for some of our community members that are impacted getting out. But I do know that how is Oxford in their voting-based system? That's something that you'd left out. I know that some people have to be voted in and they're able to be voted out. And I've noticed that a lot of our BIPOC community members, our LGBTQ community members, or even some of our community members that may or may not use SUD, get voted out, which ends up impacting them more so. Has there ever been a discussion about working around that or any type of structure to assist those community members? Because I know that when I did previously work for DOC, I had a lot of trans community members and Black community members that were out there in some of the rural areas and did not get an opportunity and was kicked out. And in some spaces due to racism, or in those spaces they didn't have enough cultural competence or humility in that space. But I just the voting-based system for Oxford really is scary.
Yeah. Yeah,
So
I mean,
can we touch on
it's
that?
unfortunate that, that stuff is still happening, still going on. I also, before I joined HCA, I was a peer bridger for the Great Rivers region. And I had some folks, transition out of Western State Hospital into Oxford House, and they also didn't do very well there. It's just, I don't really know what to say. I mean, the democratic process has been happening in Oxford House for, close to 50 years, and I don't see them changing that process anytime soon. I think
Heather?
just all of us. Yeah.
This is Mo. I would like to talk about the technical assistance that our outreach workers do provide to the homes. And this is something that we could encourage them to provide more technical assistance to the homes around these topics as well.
For sure.
Great, Malika, go ahead.
Providing technical assistance is cool, I guess. But what I really feel like is being glossed over here is that, I mean, democracy, be really frank. Democracy does not typically include, in this country anyway, and in situations where it's being replicated in the same manner, the same people get marginalized over and over and over again. And I feel like that's what Deontay is bringing up. And so so what has changed about the way that you provide technical assistance as an entity that receives public funding? HCA receives public funding and they're putting it into these private entities. So in what way will HCA be changing the technical assistance that's provided in order to ensure that this pattern of discrimination is not repeated? Like, that's the thing that we never seem to get to. It never happened in any of the SURSAC work groups. And so it's always that same sort of answer of like, yeah, it's unfortunate that that happens. So what's HCA gonna do in order to provide technical assistance and have accountability measures that will stop this pattern?
That is a great question, Malika, and I wish I had a better response for you right now. Perhaps this is something that you and I could come together with and along with Heather and have discussion around.
Well, I mean, and this isn't directed at you, Mo. This is
I
just
know.
a comment. I've noticed throughout this whole process, me as an individual having a conversation with people at HCA does not necessarily change things. And so this is like a systemic issue. And it would seem to me that having conversation with people that have been impacted and then also following, there's supposed to be an equity plan. From what I understand, HCA is supposed to follow it. Everything, all your programs are supposed to follow it. So what does the checks and balances that you all have at HCA say about how you will address these patterns of behavior? And that's not necessarily a question probably directed at just you, Mo, or Heather, because I'm not trying to attack you. What I'm trying to get at is like, how are we going to actually address this in a meaningful way, since so much funding is going towards this, and we didn't get these same sort of like ROI, points and all that other stuff on what was presented earlier. And Lisa, I really appreciate that you referred to like an accurate definition of harm reduction. I super appreciated that. Anyway, but I just feel like there's just this lacking of accountability around it. So I would just hope that that's something that can be looked at and addressed.
Thank you, Malika.
Can I just a follow up too with Malika's comment, because I think you bring up a good point. It's really not a technical assistance, but more like do you have an oversight committee if something comes up as a discriminatory practice or a concern? Where does that go to, and and is there a policy that's written up? We do have these equity measures, but yeah, to ensure that this type of thing, it's really not technical, but more investigational. Just a different play on language, and to consider, what would happen when these things come up, because we want to avoid it.
And if we actually want to address health disparities and social determinants of health, it would seem to me that HCA would be invested in doing this across the board, because it's not just Oxford houses that this kind of stuff occurs in.
Yeah. I'm going to share a link in the chat just if anybody
Heather.
wants. anybody
Yeah,
wants
that is
to.
Michael. I think that this request about what is the process when discriminatory practices are taking place, that we should come back and report out on. There is a process for what those things can be reported and how that happens and who investigates and what kind of resolution happens. So I think that we could come back and provide a report on that. In terms of Oxford specifically, I think that we have a long-standing relationship with Oxford Inc. The number of people that have been supported in the state is tremendous. And if there are homes or specific cases of discrimination going on, we'd want to know about that. When we had the Oxford conference in Seattle last year, there were a lot of presentations and tables and things of GLBTQA members in homes. They talked about how that's transformed and evolved over the years. It was pretty diverse audience that was there, of the thousands of people that were there. So I think that we ought to take this back. Thinking of Oxford specifically, we could take it back, talk to our partners at Oxford Inc., and think about what training is available now, what TA is available, what can be better or improved upon. If there are patterns of discrimination, I don't know that we're aware of those patterns with real hard data, but we can certainly look into this. And Malika, you had talked about this being brought up before, and we can certainly look into it closer. So thank you for that. And but certainly through all these housing efforts that have been talked about today, Oxford included, while we have a big need yet to go, we're pretty blessed in the state to have the capacity that we do have and the thousands of people that do get supported each and every day and week of the year. So thankful for that, but certainly room to grow. And we would take any reports of discrimination very seriously. That does not align with our values at all.
So I'm just going to push back some more. I am just, and I'm sorry, James, I saw your hand go up, but I just feel that because it feels like there's a bit of defensiveness, and that answer didn't really get at the concerns that are being raised. And frankly, I don't know that not that I know of. I mean, that there's any process to follow up with the people that are voted out of a house. Or what happens when people fail, quote unquote, fail out. You can't see my quotation fingers, but when people fail out of a system or treatment, there's generally not much follow-up that happens with people in order to capture what happened. So it feels a titch disingenuous to put the burden upon a person that is in a who has just been destabilized with their housing, that it's their job to find new housing, stabilize their life, make sure that they follow the not easy reporting process in order to be able to file a complaint around what happened with the healthcare authority around what happened when they were voted out of housing due to the discrimination that we're speaking about anecdotally. So that again lends itself to what is HCA doing in order to make those mechanisms of report more easy and simple to engage with, making sure that there's true accountability and that we're addressing this across the board. So, and I'm not looking for an immediate answer right now. I'm raising the question, and I'm hoping that it will be something that can be thought about, and that it won't be done in a reactive or in a defensive way, that it will be done in a thoughtful and thorough way so that we can actually start addressing health disparities.
All right, thank you, Malika. Hunter's had his hand up for a bit. Sorry about that, Hunter.
It's all good. Good morning, everyone. I just had a quick question regarding the Housing First presentation, and I also apologize if any of these details were addressed and I missed them. See, I'm curious if there's any like previous instances or projects that we can refer to So I guess rate the efficacy of housing first, like I guess from like a legislative standpoint, how can we assess the positive effects that could come from it if there's something to compare it to, you know?
That's a great question. This project just, the contracts just went out, or the project just started up in January of this year. And so we're going to, we already have contract with RDA to make sure, and Commerce to make sure that we have data, good data of how many services are being provided, and what type of referrals, the length of time, who's being served, demographic wise. But you're seeing like the evidence-based practices of a housing first model. You want to know, how do we know that this model works? Or do you want to know, because we have evidence-based that shows housing first models do work, that they're a best practice. But a baseline to where we are today versus where we're going to be maybe a year from now or 2 years from now, is that what you're asking about? I mean,
Yeah.
in my update.
Oh yeah. I was curious about both, like mainly the evidence-based. So I think having the evidence is pretty important. But yeah, thank you for addressing that.
Yeah, I'd be happy to put a link in about the housing first model. Actually, I'll add it to the PowerPoint that will go out with Michelle. I'll add that as a resource so you can see that there. And then I'm really excited to be able to share what we do in Washington State with the expansion piece and the demographics and information that comes out of that. I hope I answered.
Oh yeah, thank you.
Thank you.
Thanks, Hunter. Okay, it looks like we are going to, it's time for our second comment round. So if anybody from the community has to add, please go ahead and raise your hand. All right, James.
Yes, thank you. In response to the very serious issues of equity brought up around housing in general, specific the voting quality of Oxford housing, I propose that the tracking of recovery residences by HCA according to RCW 4105-760, there seems like there might be some room in there for using that registry as a starting point for some of the oversight. I know the legislature for that from 2019 doesn't reach that far and doesn't touch on equity, but it does seem like there's a jumping off point here for us to actually have some frame of reference, oversight, and even censure if needed for issues of equity. That's all. Thank you.
Thank you. Any other comments? All right, last call for public comment. We'll move on to agenda.
Just so that I apologize for speaking out of turn before. I am actually a committee. I'm not on the committee, so if you could strike any of my comments from your official transcript and put me into the community member. Thank you.
All right, thank you. Okay, let's go ahead and move on to the agenda. Sounds good. We have one item that we're going to need to follow up on. Michelle, do you want to show what you got?
Yeah. So I apologize. I think I mentioned at the last meeting I intended to send out a survey on these items, but I'm hoping we can basically do that together now to see where there's interest in these different items for the April meeting. The May meeting will, a big chunk of that will be dedicated to summarizing what happened during the legislative session and where we go from there. But April is our last meeting during session, so want to make sure that we're using that time in a way that you all want to, that's addressing high priority items. So want to recap, this is what we've heard so far about topics. So there's the topic of addressing stigma, and there's a few pieces to this. So discuss and teach strategies to talk about stigma, communication skills, the myth of rock bottom, also how data collection can perpetuate stigma and how to improve data collection methods, who is working to address this issue, who can we learn from, how does stigma among youth and stigma reduction strategies differ from stigma among adults. We could review the Healthy Youth Survey, CDC survey, Young Adult Survey. So I see that as like a whole meeting, like the whole meeting could be dedicated to that stigma conversation and those different pieces of it. Another big topic would be around media and messaging. So this would be about options that the committee has for influencing or creating media, what types, for what audience, for what purpose. So there's been mention of public health campaigns, creating a media packet for the Blake programs, a SURSAC statement or declaration about overdose prevention. So different, SURSAC input about public facing talking points, et cetera. So, it's difficult to say what we can commit to around any of this until we know what is wanted, and we would have to have that conversation, first. And so, but anyway, there's that topic, the stigma topic, and then there's also a discussion around public safety. For example, how to encourage recovery, not criminalize people, and also maintain public safety. Also a discussion around Kratom, so risks, benefits as treatment for SUD and addiction. And I want to just point out the work groups, for example, Safe Supply and the SUD intake. Those were also mentioned previously as topics for discussion, but we're just going to hold off on those to see if there's any legislation around those before moving into those conversations, because there may be legislation around it and potentially around these other things as well. But we do know that 5536 has some language around the SUD intake work group. So in any case, kind of putting a pin in those two things. So what we're looking at for April is what's on the screen now. So I think how to do this, we've got just a few minutes left, but if we could do just a quick hand raise for each of these topics, if you're interested in putting it on the agenda for April, and then whichever one has most interest, we'll make that happen and try to get these other items on subsequent agendas.
Michelle, can I clarify
Yeah.
that
So like you cut out, are you speaking?
Yeah, I'm sorry. Can we confirm that the Oxford discussion, that the follow-up on that is a given for next time around, despite these other?
Follow up on, you said the Oxford discussion, was that a comment in the chat?
No, it was just a comment about the voting and so forth, and us following up on that.
Yes.
Okay.
We can provide a follow-up in the next
Thank
agenda on that. Yeah.
All right, thanks.
Okay, so committee members, whoever would like to focus on addressing stigma at the April meeting, please raise your hand now. And we'll just take a quick poll on this. All right, I'll wait a few more seconds. Looks like we had 4. Oh, sorry, I'm not going to count non-committee members in this vote. So we've got 3. Okay, all right, you can put your hands down. And then who would like to, and you don't have to choose just one here, who would like to discuss media and messaging? All right, I saw 5 total there. Okay. Sorry, okay. And then I think, John, that made 6. Okay. So you can put your hands down. And then what about the discussion of public safety? Encouraging recovery and also maintaining public safety. And if you'll just keep your hands up. All right, 5 more seconds. Okay, and that's 8. All right. Thank you. And then finally, and I'm not sure if I'm pronouncing this right, but Kratom, who would like to discuss that? Okay, we'll wait about 5 more seconds for hands. Please keep them up to get a count. Okay, so see 3 committee member hands up. All right. So you can put your hands down. Looks like the top priority agenda item for next time will be a discussion around public safety. Like I said before, we are still going to try to get to these other topics. Just want to make sure we're doing it based on the priority for you all. So I think that takes care of the next agenda. And with that, we can go to follow-up. And for next time, and I do want to just give everyone an update around the directory. We received about, it wasn't half. It wasn't at 50% of you who responded. So we're going to try to figure out something to do with those responses. If you would like to do anything with them, I'll follow up over email around that. And is there anything else you want to say on that, Michael, around the directory?
No, thank you for those that reported or that completed your applications. It was interesting to complete. I completed mine as well. But again, it would be a directory of a minority of the committee if we were to publish it now. So one thought is when we begin to meet in person, we can take turns and kind of maybe read over our bios a little bit, if that would help. We could also do that virtually, just take a moment and have maybe 3 or 4 people each meeting kind of tell a little bit more about themselves. This is in response to the request of the committee to learn a little bit more about who's on the committee and what backgrounds they have and things of that nature. So if it helps in the team building of the committee members and we get to know each other a little bit better, then we're willing to pursue this, and certainly would like your feedback on next steps. But at this point, we didn't feel comfortable publishing something that had less than half the people sharing their experience. So, thoughts? Caleb, looks like Caleb's hands up.
Yeah, Amber's up.
Okay,
Amber, then Caleb there.
Is my hand still up? I can't tell on this new version
It is.
of chat. I am so sorry.
All right, we'll count your vote under stigma too. I saw that.
Okay,
Caleb,
thank you.
Caleb, go ahead.
Yeah, hi. Teams is being wicked glitchy today. I can't tell what's happening or not if my stuff's getting posted in the chat. But I'm confused by I missed the January meeting, so maybe I missed this, but I'm confused how some of these topics are part of the scope of SURSA. And in fact, what our scope is. I thought it was mostly monitoring the RMP. I thought we weren't allowed to make any more recommendations going forward. So I didn't vote on most of those things because I didn't really understand how they were in scope. It's a question. I don't understand.
Yeah.
Are we just, I mean, is this just a drug policy forum? And it's like just for general knowledge and information and discussion. I mean, that's a thing, but that didn't seem to be our mandate.
Right. So yeah, thanks for bringing that up, Caleb. It is, you know, now that we've identified what discussions we want to have here, we will also identify the objective for those discussions. You are correct that we're not making more recommendations to the legislature. That time has passed. So, you know, there was discussion in the January meeting about how we want to use this meeting time, since, you know, committee members said they want to continue meeting monthly. So we're asking, what do you want to do during those monthly meetings outside of the RNP quarterly review and outside of the annual report review and those kinds of things? And so one of the things that was brought up was using the space to have discussion on different topics, learn about different things. And so, yeah, I look forward to hearing, you know, if there's any other kind of specific objectives that people want to get from those discussions. But that's up to the committee. And so we want to be really clear about what we can do on our end, you know, at HCA, and what audience there would be or would not be for any kind of recommendations that or conclusions, you know, that come from those discussions, what we can do and, you know, what we can't really do with those. So yeah, good question. All right, and we are a minute over, so I think that wraps things up. Thank you so much, everybody, for being here, and we'll be in touch soon.
Thank you.